And our next speaker is Dr. Tejas Ozarkar. So he is an Ivy League trained, double board certified physician in pain management and physical medicine rehabilitation. And he's the medical director at the Riordan Medical Institute. He'll be talking to us specifically about stem cells for the aging spine. So please welcome Dr. Tejas.
Thank you so much. Welcome everybody. How's everyone doing? I'm going to talk about spine pain today and how stem cells can help. So all the people who are sitting on the edges today, come see me for your neck on Monday, all right? Or you guys can absolutely move around to help even out your neck. But anyways, like Cecilina was saying, I'm an interventional pain doctor, and I'm the medical director at the Riordan Medical Institute, which is just a couple miles away from here, and I'm an assistant professor at the local medical school here. And just a little bit about me, I went to undergrad and medical school at Texas Tech in West Texas, and then I went on to Philadelphia, the University of Pennsylvania, where I did my residency, and I went back to Texas Tech to do a interventional pain fellowship. I moved to the Dallas area in 2017 to start practice in interventional pain management, doing conventional medicine, where I did steroid injections and wrote prescriptions for opioids and ablated nerves and stimulated spinal cords, and I did all of the conventional interventional pain management stuff. And although I thought it was incredibly exciting at the time, which some of the advancements are incredibly exciting, there was certainly something that was missing. And what I saw so commonly was that patients who just wanted to move on with their life needed to come back to me all of the time, and it was such a drag because a steroid injection only lasts so long, and ablating a nerve lasts only so long, and sometimes when we're dealing with insurance companies, we're only allowed to address a small part of your pain, and we can't give you a complete treatment. And so when in the midst of the pandemic, when everybody was reevaluating their lives, I had an opportunity to join Dr. Riordan here as the medical director, and I really enjoyed my previous practice. In fact, I enjoyed it so much that I continue to work there a couple days a month just to help out my old doctor. But ultimately, there was something that was missing, and I really saw that a lot of the patients that I treated with regenerative medicine, whether it was PRP or bone marrow, in my previous practice. And in my previous practice, we did not have the fancy technology that I have access to now as the medical director of the Riordan Medical Institute, yet patients still did slightly better than when we would inject steroids and other things. And I'll talk a little bit about what we do at the Riordan Medical Institute, why we're a little different, and why we can really provide some robust treatment options, and why following the path of insurance and assuming that they have your best interests in mind is a fallacy, and what we can do to kind of hopefully provide you a really robust response for your orthopedic conditions. So the old practice is injecting steroids, like I've been referencing over and over again, writing prescriptions for NSAIDs like ibuprofen and Celebrex, and writing opioids and other types of medications, and everything has a time and place. Sometimes a steroid injection is the correct answer, sometimes an opioid is the correct answer. However, when we over-apply it, which is exactly what's happened in the field of interventional pain management, it's exactly what's happened in the field of orthopedics. Like Dr. Paz was saying, when people have tried a steroid injection or two and they've gotten the hyaluronic acid injection, then suddenly it's time for a knee replacement. And it's kind of it's a bridge too far, frankly. I mean, and we have all of these other therapies that we have access to that can really extend the life of your native tissue, your native knee, your native your spine joints, everything. And so that's the part of the new practices, using things like shockwave and laser therapy and PRP, exosomes, and culture expanded cells. Those are the types of things that are available offshore. The types of things that we primarily use at the Riordan Medical Institute is we do use some perinatal tissue products like umbilical cord tissue allograft, but we also do bone marrow procedures, PRP procedures, and various other regenerative medicine procedures. And so dealing with any type of pain, you have to kind of realize where you are. Acute pain means that it just started, typically in the past 3 months. And most of the time, it generally goes away on its own. But subacute, subclinical, that's the type of person who throws their back out, once a month or once every other month, and they've been doing that for the past 10 years, and the frequency is just increasing, and it's a huge drag on your entire family and all your vacations and all the things that you want to do, but it comes and goes and it's not debilitating. Chronic, on the other hand, is the same type of pain in the same area that you have kind of continuously, that seems to be unrelenting, and the types of patients that we see a one-and-done treatment, meaning that we do the procedure and they get incredible results and it lasts. Those are typically in these first two groups, the acute and subclinical group. The chronic group, which means that some of the patients I've treated have had the same pain for the past 30 years in the exact same area. And even though our intervention was able to help them and reduce their pain, sometimes this group will need reapplication, and a strategy that we take a lot of times with Dr. Paz's team and Dr. Sierra at the Stem Cell Institute is sometimes they'll get an initial treatment with the culture expanded cells in Panama, and then they'll come visit me in Dallas. And I'll do follow-up treatments, because sometimes if you have a big problem, you got to chip away at it. And unlike conventional medicine, when we chip away at a problem, there is a real opportunity to reconstruct that body part, especially in the field of orthopedics. We can see disc heights improve, we can see the disc thickness improve, we can see cartilage repopulate itself, we can see tendon tears repair themselves. But once again, the longer it's been around, the longer you've been dealing with it, the more debilitating it is, likely the more applications of treatment that you need. And so we're always happy to discuss a strategy with you, and that's one of the really cool things about this job is we can really tailor the treatment that you need to get to the finish line. And so one thing that I always like to insist with patients is identifying a good doctor, a good treatment center, and it's tough to do that sometimes, especially if you're looking for emerging therapies and new therapies. The types of providers and practitioners who tend to be the first ones to offer this stuff are not the well-trained subspecialty physicians and not the pillars of the community. It's many times fly-by-night business folks who hire a random person to do whatever they want to do. And so one thing, just to start from the top, is your doctor must do a physical examination on you. They must talk to you. They must get an understanding of what your pain is, where your pain is, and then they have to look at your imaging. They need to look at it with you. When you do an in-person evaluation, they should be walking you through what they find on the MRI or on the CT or on the X-ray and how it pairs with what they found when they've talked to you and they've done a physical exam on you. And I take it a step further because I have the luxury of time at the Riordan Medical Institute, and I have an opportunity to get to really know patients. So I do something called dry needling, which is commonly done by chiropractors and physical therapists, and it is a great therapy in their hands. I use it as an extension of my physical examination because I take acupuncture needles and I just pepper them across all areas of your neck or your low back, and I see several patients that I have treated here, and they're all smiling from ear to ear with when I bring up dry needling. And so but basically what I'm trying to get at is that your doctor needs to know exactly what your problem is and exactly how they can help you, and it give you a real idea of whether this therapy is going to be helpful and what types of things make you a good candidate and what types of things make you a not good candidate. They need to be thinking about these things, because if they are not thinking about these things, that means that they probably don't have very much experience with what they're offering you, which should make you pause because you always have a lot of options, and you need to make sure that your doctor knows what they're doing. And that is what is absolutely offered at the Stem Cell Institute. When you go there, you realize how well trained the physicians and the entire facility staff are. And then we hope you feel that exact same way at the Riordan Medical Institute. And I see a few of our treated patients here, and so hopefully some of them will be willing to answer questions if you have any questions for them, because there's no perspective like the patient's perspective. And so the other, I wanted to quickly go over how to manage these types of pains. So if you have a new pain, an acute pain, then you need to start with something easy, like maybe some over-the-counter medications, maybe just stopping and resting, icing, heat, that kind of stuff. I will not take NSAIDs like ibuprofen and Celebrex and those types of things for more than 3 days without, at the third day, I'm like, I really need to get this checked out, one way or another. Go to your physical therapist, go to your chiropractor, go to whatever doctor you trust, try to find a specialist, and try to start figuring things out, because just masking the pain is not going to serve you well. But beyond that, it's a real opportunity for you really to change the course of your disease if you catch it early, exactly like what Dr. Paz was talking about. And I'm a big fan of chiropractic and physical therapy. I think that is an essential way of moving forward and rebuilding your tissue. And then you really do need some of these advanced studies, sometimes an MRI, CT scan, x-rays, those types of things. Don't let your insurance company guide you and guide your care, because if you feel like you need to get something investigated and they say you need to suck it up and wait for 6 months or 6 weeks or whatever, I mean, they do not, their goal is to try to get you to stop spending their money, and frankly that's inappropriate, and you need to find a doctor that will help you navigate that system as best as you can. And so I put this image up here because this is how a doctor needs to walk you through images. They need to pull it up. They shouldn't just be looking at a piece of paper and say, oh, it's bad. Oh, you're going to need all the surgery or whatever. They need to pull up the image so you can look at it with them. And if this were your spine, this is how I would go over it. I would say, I'm going to kind of do this in 1.25 speed here, but you have your belly right here, your backside right here. This is your low back. These are your spine bones right here, and in between them are your intervertebral discs. And what we see here, up here, is we see a high quality disc with white on the inside, black ring outside, back margin of the bone, back margin of the disc all in line with one another. We see that there's a little herniation here. We see there are two herniations down here at L4-5 and L5-S1, and we see this little white dot right here, and that indicates that there is a annular tear right there. This yellow line indicates the axial cut, where we're cutting you in half. And so what we see here are, we see the facet joints. We see a little bit of fluid inside the facet joints, indicating that there's inflammation inside of it. We see that huge disc herniation and that little white piece right there, indicating that there's a lot of inflammation right at that disc. And then we see the muscles right here, and we see that this black stuff is a high quality muscle and the white stuff is basically gristle. And so what the conventional medicine doctors are not able to do is they are not able to address all of these problems at once. Because if you've been living with back pain for 10 years, and I can tell you, this person has been living with back pain for quite some time, and every time it gets terrible, they get a steroid injection, which seems that it takes the horribleness away, it cuts the edge out, but they live with this chronic pain forever, and they are wondering what the next thing is that's going to set their entire back off. And in the insurance world, that's all they care about. They care about controlling your pain so you shut up enough to move on to the next year and hopefully move on to the next insurance plan. But we have the freedom to do what we think it takes to control your pain long term. And so what I would do at the Riordan Medical Institute for this patient is I would try to hit all of the anatomical areas that are problematic. I would go inside the disc. I would inject right across that white area right there. I would inject inside the facet joints. I would inject all across these muscles because we consistently are able to see that if we do this process correctly, that we can convert some of this gristle into high quality muscle. And I want to lift all of the anatomy up together. And that is the type of thinking that it takes to get you a robust answer to your big problem that is a major drag in your life. And so when I was in the insurance world, we would have to pick and choose what we wanted to do. And ultimately, by the end of the year, the patient would balloon up like the Michelin Man because we did various steroid injections in various parts of the back, and they would just keep coming back, and we would treat one part of the pain, and it was just like a horrible game of whack-a-mole. You try to treat this, something else comes up, try to treat that, and then they're your forever patient, which is a great business model for doctors, but it's not the future of medicine, and it's not what you want, and it's not what I want for me or my family members. And so this is what you should be looking for when you're considering getting treatment for any of these conditions. And so specifically, when we look at spine treatments and how to control spine pain, this is an emerging field. Using stem cells to control back pain and neck pain is an emerging field. But we still have some pretty high quality evidence. And so I'm going to reference 3 studies here. And I also just want to quickly mention that we have an approved clinical trial where we are able to give patients IV stem cells for a few days, and then also inject the exact areas of where the pain is being generated using X-ray and ultrasound guidance. But let's go over these studies really quickly. And so first, I want to look at Dr. Otleri's study where he used same-day bone marrow procedure to treat back pain. And this is, they had about 100 patients in the study, and most of them got pretty excellent relief. And what Dr. Otleri did was he would take the bone marrow, he would spin it down, and he would re-inject it into the disc, the facet joints, the epidural space, the muscles, kind of like we do. Yet, I really need to mention that, we do want to kind of look at this number right here is the important number, 66%. At the 6-month mark, about 2/3 of the patients had pretty good results. And I'm going to show you our results a little later. We do better than this. We have older patients on average than this. And I would say we have patients sometimes in a tougher condition than the types of patients that they did in this study, and that is because we are able to leverage multiple regenerative medicine options together, especially using that umbilical cord tissue, using the bone marrow, using PRP, leveraging them all together in a very particular way that we've slowly massaged our protocol since 2014 to become what it is today, because that's what it takes when you're doing pioneering stuff. And so when you just use bone marrow stem cells, the results are still pretty good. And we can see, so ODI and VAS, that's the VAS is the pain score, and the ODI is called the Oswestry Disability Index, and that is just a overall index of how functional that person is. And we can see this blue line right here, the lower the ODI, the better it is. And so we can see there's a huge drop in the ODI, meaning that the patients got great relief and great functional improvement, and then the control group really didn't see any improvement over the course of time. And then in terms of the pain, we see a pretty decent drop, and then it kind of stays there. And so the other thing that I wanted to really point out was that he counted the number of cells there were in the bone marrow, and he tried to kind of put it on a scatter plot, and generally the more cells you use, the better it is. But that's not always the case, because sometimes people have a crazy number of cells in their bone marrow, but they still didn't get very much improvement. Sometimes you have a medium amount of cells, and sometimes you get decent improvement. And so that's where a little bit more research needs to be done. However, what we find is when we leverage these technologies together, that we get a 1 + 1 = 4 effect, because we don't really necessarily care so much about how many cells you're bringing to the table, because we can add to that. And so, and we can really kind of spice up your own bone marrow or PRP or whatever we're using to hopefully give you better results. And we'll once again, I'll present those results in just a second. And so the other study that I wanted to bring up was the allogeneic MPC intradiscal injections. This was done primarily in the United States and in Australia. They had 100 patients. This was mostly a safety study where for 3 years they tracked the safety of putting stem cells directly inside the disc. And I want to point out the complication rate. It was about 1%. And so really of the 100 patients, one of them had some sort of complication or adverse event that did not require any surgical intervention or did not require any major intervention. Dr. Riordan and I had the good fortune of actually discussing this protocol with the physician who was responsible for monitoring the safety and adverse events. And what he told us was that he's an interventional pain doctor and he's published a lot, and what was most surprising to him was that the risk of injecting inside the disc when you use stem cells is drastically lower than injecting inside the disc just contrast, which is called a discogram, which used to be a commonly performed procedure. So even when you're injecting, kind of nothing into the disc, just contrast, it has a higher complication rate than injecting stem cells into it. And so that was mostly the safety study. And the third study I want to quickly go over is by Dr. Noriega from Spain, and Dr. Paz, Dr. Sierra, Gabriel, who's the CEO of Stem Cell Institute, and Dr. Riordan and I had an opportunity to he actually flew to Panama, and we got to meet with him and discuss this case and discuss the future as well. And the one thing I'll tell you is that he was incredibly excited about what we could do in Panama and what we can do in the future because they're just very limited. His clinical trial was kind of limited in Spain. So they use the patient's own bone marrow stem cells. They plucked the good ones out and they grew them in the lab. So they cultured and expanded those stem cells. And then they injected it inside the disc. And what he did, what other people don't really have the opportunity to do, is he measured the thickness of the disc. And so when he treated those patients, the higher this number on the Furman stage, the more degenerated the disc is. And what he saw was over the course of the year, it dropped by 0.5 point in that Furman index. And once again, this is using the patient's own adult, old, tired stem cells. But they still got this result. And then the control group, meaning they got nothing, it was actually a sham procedure. Their disc just continued to degenerate more and more. And then they also got some pain relief, but not complete pain relief, but some amount of pain relief. And so what a lot of these centers are doing is that they really only target one area. They're still in that insurance mindset where they inject only inside the disc and they say good luck. Whereas when we create a protocol, we want to attack the pain from every single angle, giving you an IV infusion to mitigate the inflammatory response in your entire body, putting it directly where the problem is so that we can rebuild that tissue. It takes all of that to lift your entire body up so you can get on with your life and start moving and doing whatever you need to do. And so that's why Dr. Noriega was so excited about what we are doing and why he flew all the way to Panama to discuss our treatment options. So when we look at our results with what we do here in the United States, when we look at our low back population, we have a couple of patients who have had their low back treated that are here today. So if you have any questions, then we would love to connect you if our patients are nice enough to stick around for a moment after this. So 77% of patients had pain reduction and functional improvement in our low back population. When we look at our neck, it is 92% of those patients had pretty good results, and we have several patients who've had their neck treated here as well. And then then when you look at joint pain, it's about 77% as well. And I want to mention that we have all comers. There are certain of our patients who've had 13 back surgeries, and to them, a 30% improvement in their pain is tremendous. And so even though our survey system, which we send every single one of our patients to survey at 1 month, 3 months, 6 months, 12 months, 24 months, and beyond, just like the Stem Cell Institute does, because we want to know what works and what doesn't work and how we need to change our protocol so we can give you the best possible treatment. But we have all comers, because I understand that if you have no options and you've tried everything and you're just looking for a little bit of improvement, that it's worth trying. And so even though our survey system will say that the patient did not have satisfactory pain relief, the patient may be happy. So this doesn't capture the nuance of what a patient is actually feeling. But for the most part, I mean, we do have plenty of patients who have resolution of their symptoms. We have plenty of patients who are able to help avoid surgery. We have plenty of patients that do incredibly well. And really, with neck pain, I mean, honestly, I have not seen any other treatment do what we can do for people with neck pain, which is once again, as I mentioned earlier, all you people on the sides, think about me on Monday and call our office. I also want to discuss some of the positives and the negatives of this, because every treatment comes with some risks associated with it, but we'll go quickly over the positives. So in some cases, we can help you avoid a surgical intervention or delay that surgical intervention, or maybe even minimize the amount of surgery that needs to be done after our treatment. We also, some people have lasting results, some people have complete resolution of their symptoms, and then the typical return to doing whatever you need to do after the procedure is pretty easy. It's about 2 to 4 days to recovery, and usually the post-procedure pain is mostly gone by then. Maybe for a couple of weeks it's a little sore, it goes up and down, but pretty much whenever we do a procedure on Friday or something, like we typically do our anesthesia-based procedures on a Friday, most people, practically everybody, is back at work on Monday. And so you might feel a little bit of additional soreness, but it's usually just kind of a magnified version of your usual pain for a few days or up to a couple of weeks. But most of our patients don't take opioids after this procedure. Most of our patients maybe take a Tylenol here and there, maybe have to ice a little bit here and there, but it really does not affect their lives too much. Some of the drawbacks are that this is an out-of-pocket cost. It is not covered by insurance. Sometimes there are some very generous insurance plans that are willing to help out. You need to call your insurance to see if you're one of the very few lucky people who may qualify for that. But we don't file insurance, and most places like this won't file insurance, because then that limits what we do. And that means that someone else is dictating what we're trying to do for you. And that is, frankly, between the patient and myself, what I need to get accomplished. And so this is not FDA approved. No regenerative medicine products are FDA approved. PRP is not FDA approved for orthopedic use. They may have some wound care applications or whatever else, but none of these regenerative medicine products are FDA approved for orthopedic care. It is not it's not very effective on neuropathic pain. We have a lot of patients who come to us with diabetic neuropathy. We have a lot of patients who have a big disc sitting right on top of one of their nerves in their neck or their back, and they're having a lot of fiery pain down their arm or down their leg. Unfortunately, this treatment is not so great with those types of treatments. But, I mean, at the same time, once again, we still have an opportunity to mitigate the amount of surgery that you might need, or that we come up with a lot of strategies. We work with a lot of surgeons in the community and the surgeons that I work with know how I like it. I like motion sparing surgeries, meaning that I want my patients to be able to move that joint or move that body part as if they didn't have surgery after they've had surgery. I want them to do it in the most minimally invasive way possible. I want there to be evidence behind what they do. And so either way, whatever type of pain, orthopedic pain you have, I would consider applying to the Riordan Medical Institute, because we can curate your path forward, and we can tell you who our partners are, and we can just show you a different way if you are not satisfied with what has been offered to you. And some of the risks associated with any type of spine injection, any type of minimally invasive procedure, there's always a risk of bleeding, worsening of your usual pain, infection, spinal injury, nerve damage, irritation, hematoma, and injection site soreness. And this is why it is incredibly important that you choose a doctor and facility that has done a lot of this and has the appropriate training. I can't tell you enough how important that is, because there are a lot of things that we take into consideration to mitigate risks of infection and risks of bleeding. There are a lot of extra steps and a lot of extra tools that we use because we do such a subspecialty based thing. And if you're going to somebody who's just picking this up or just went to a weekend course a couple weekends ago and kind of wants to test this out on you, just understand that this is not a no medical intervention is no risk. And so you want to mitigate that risk as best as you can, and you need to go to the experts. That's how you mitigate that risk. And so I wish I could show you some before and after pictures of some of the patients that I've treated, but I really, really wanted to do a case study, because we have such limited time, of a patient who went to the Stem Cell Institute in Panama for a heart condition. I am not a cardiologist. I do not treat heart conditions. However, I have a special interest in this because literally every male and most people in my family tend to die from heart disease and heart-related conditions, so I have a vested interest in learning about the heart. Anyways, we have a 71-year-old male who's had has had a massive heart attack. He's diagnosed with heart failure. He's had open heart surgery, he's had stents, he's on all the right medications, doing all the right things, he's compliant with everything, he does the cardiac rehab, he has 6 different doctors that he goes to, and he does what every single one of them says. And so he had an open heart bypass in May of 2021, and then despite having all of that heavy medical intervention, which I don't think was the wrong thing to do, but despite all of that, he had a big hospitalization in March of 2022 with a severe acute on chronic heart failure exacerbation. His cardiologist is now incredibly concerned. They're considering hospice options. They're considering placing an LVAD. If you've never heard of that, it's this big machine that sits outside of your chest with 2 pipes inside your chest and it pumps your blood for you. It's a drag. I'll just put it that way. And so he went to the Stem Cell Institute in May of 2022, and then he had follow-up in July of 2022. And so these are his echocardiograms. And so before I start, I just want to orient you a little bit. And so this one was the one to my right, to y'all's left, this one right here. This echocardiogram, I want to walk you through this a little bit. So these are the chambers of the heart. This chamber right here is the left ventricle. That's the one, that's the important one that keeps you alive. That pumps blood into your body. And so as you can see here, all of the chambers of the heart are very dilated. There's a ton of black inside all of these chambers, indicating there's a lot of blood that has pooled inside the heart chambers, and the heart is finding it very difficult to pump that blood into the body. And so this one, I just want you to notice how much black there is. And then this one in July of 2022, you can see it's the same heart, it's the exact same person. It's just, the size of the chambers is drastically reduced, including in the left ventricle. And now I want to show you the videos because, and I'll walk you through the videos quickly as well, but it just shows you, this is objective evidence. I will tell you how this person is doing, and I will tell you all the things that you want to know, but this is objective evidence, this is ultrasound image evidence of what happened before and after stem cell therapy at the Stem Cell Institute. This is not available in Dallas. This is only available in Panama. So this is when he was hospitalized. And so you can see right here, if you look at this guy right here, the left ventricle, it is floundering. If you imagine somebody who's in the middle of the ocean, can't catch a breath. I'm gonna play it a couple of times here. And it starts moving, and you can see this chunk of the wall right here doesn't have very much motion, and all of this black stuff in the middle right here just stays there. The blood is not being pumped into the body. obviously a big issue. That is why the cardiologist was calling in the hospice doctors and calling the heart surgeons to place that terrible, that device in this person's chest. Now, this is so he was treated in May of 2022 at the Stem Cell Institute. This is July 2022, just about 6 weeks after his stem cell treatment. And so you can see right here, there's a lot less black inside, which means that blood is being pumped somewhere else into the body, which is what we want our blood to do. And then I'm going to play this again, and I really want to focus on this left ventricle right here, because the left ventricle is the big one. That's the one that pushes blood into the heart, and it's the one that really needs to work. And so when we look at this again, we can see, especially in this part of the heart, there's a lot more motion. There's a lot more motion all around. All of the heart muscle is working better. All the blood is being pushed into the system much better. And so when we look at the results, so if you've ever heard of an ejection fraction, that's the efficiency in which the heart pumps the blood. A normal ejection fraction is above 65%. When he was hospitalized, when it looked like, when you could see all that black inside the chambers, all that blood inside the chambers, he had an ejection fraction of 16 to 20%. With severe left ventricular dilation and dyskinesis. That means that a big chunk of his heart muscle wasn't working, was not pushing blood through the system. And then when we look at the read from the cardiologist in July of 2022, we see that the ejection fraction is 35 to 39% with a reduced left ventricular dilation and better heart muscle function. And in fact, I know this cardiologist very well. And in fact, unfortunately, one of the weird things that we have to do in the United States is doctors have to play this stupid insurance game. If the ejection fraction was over 40%, this person would lose coverage of their heart failure medications. And so no one who is trying to be benevolent will ever read anything above this. And so this person happens to be my dad. He's here today. And so, and I cannot... The amount of emotion that comes over me when I look at this echo, when I talk to his cardiologist is my friend from high school. Her kids play with our kids. We're going to hang out with them tomorrow. And when she tells me her perspective, when she came to us in March of 2022, my wife was in there with me. She had tears in her eyes because she said that people don't come back from an ejection fraction of 16% without having a major intervention, having something like an LVAD, or going on hospice care or whatever. That does not improve. And when I see that, when I see my dad, when I see how he's able to participate in life, they took an 11-day road trip in the Pacific Northwest where they stayed at 11 different places over the course of 11 days, and this was in November of 2022. He was not doing this 2 years ago. That would have been, I don't want to go to 11 different places in 11 days. And he was able to do that. We've been to Hawaii, and we've been to Panama, and we've been to all these places. I took my older kid there to spend the night last night. None of that would have been possible had it not been for this adjunct therapy. And I think that all of the things he does together, the conventional medicine, the medicines that he's taking, following up with his cardiologist, doing cardiac rehab, I think all of that is essential. You can't just say stem cells are going to do everything for me. You need the rehab. There are some aspects of conventional medicine that are incredible, that are gifts to humanity, but we need to be able to cherry pick the good stuff, and we need to be able to say there's some emerging therapies. When we combine all this together, we get a result that even specialists, subspecialists would never have expected. And so, I just really wanted to quickly go over the DREAM-HF trial. You guys might have heard about it. This was in the news. It was just published at the end of February this year, where they treated 565 patients with someone else's bone marrow stem cells that were culture expanded. So not young, healthy, umbilically derived stem cells, another adult's stem cells. But and this was a little different because they took a catheter up to the heart and then they put the stem cells there, whereas my dad just got the IV infusion in Panama, which is, way easier. And what they found was that it reduced the risk of heart attack and stroke by 58%, and really improved most people's lives in a pretty compelling way. I know a couple of patients who were involved in this trial, and it really changed their life. And so really the next steps are being able to combine all these therapies together and knowing what works and what doesn't work, and using all of the knowledge that they have from the Stem Cell Institute and using that as a jumping point to really, be able to deliver this to the masses and make this affordable for everyone so we can save the American healthcare system, which is about to, implode on itself. And we need really affordable options that will deliver lasting results for people so that we can live a long, healthy life. And so please consider today applying to our clinic, rmiclinic.com. You can ask questions afterwards. Me and the entire staff will be here, and we've been blessed to treat a lot of really cool patients. And this is our staff. That's Dusty, Anna, Amy, and I. And so we've all been working here together for quite some time, and so we would love to help take care of you. All right, and I think that ends my presentation. And so thank you all so much for coming today.